Good to go? Okay. Okay, folks, why don't we go ahead and get started with today's Grand Round session. So today we have a case-based presentation with a panel discussion. And before I introduce today's moderator, just a couple of housekeeping announcements. Please remember that this conference is being videotaped as well as live streamed via Facebook, live stream, and YouTube. So if there's any questions, because this should be an interactive session today, please be sure to use a microphone to ask any questions. And also one more upcoming conference for this month, the month of June, is the nursing conference, Matters of the Heart. So please be on the lookout for that. So let me go ahead and introduce today's moderator is Dr. Karla Kurrelmeyer. And Karla has migrated southward from Minnesota, I guess where she grew up, and slowly moved down to do some of her training in Wash U, and then eventually came down here to Houston a few years ago. And Karla now is really an expert in heart disease in women. And we thought for today, she's going to do a little case-based presentation of a few cases of kind of common or sometimes uncommon conditions that we see, but that are in women, and to really kind of compare and contrast how women present differently than men. So Karla, take it away.
Thank you, Dip. And so we picked cases today that actually had more recent information so that we could give you recent updates in these specific disease states that present in women. And to do this, basically I have the two first-year fellows. Dr. Isaac T. is going to present a couple cases. And after each case, we will have a 5-minute question and answer session with our experts. And Dr. Akanksha Thakkar, who's over there, she's also going to present a case for us today. They're our first-year cardiology fellows, soon to be second year in July. And then we have our expert panels. They'll be fielding all the questions that you have after the case reports in our 5-minute question and answer session. So we have our interventional expert, Alpesh Shah. And we have our advanced heart failure, cardiomyopathy, and heart transplantation expert, Mahwash Kassi. And the person who will be joining the panel, just running a little bit late, is Eric Yang, and he is our MRI specialist who's going to help us out with interpretation of viability. So he'll be sneaking in onto the panel a little bit later. So without further ado, I'm going to have Isaac come on up and present the first case.
Good morning. Thank you everyone for coming. I didn't think this would be the only way I get on YouTube, but first time for everything. So we're going to start today's grand rounds with this case of a 38-year-old African-American female. She's a nurse coordinator at TCH, had a past medical history of coronary artery disease. She presented with a STEMI way back in 2015. So remind her, she's only 38 right now. Had, obviously complicated by ischemic cardiomyopathy, hypertension, hyperlipidemia, poorly controlled type 2 diabetes. And so she's coming to Houston Methodist this time for chest pain. It's about 4 days, intermittent central left-sided chest pressure, no radiation, but became constant. Started at rest while she's watching television, but really not very classic, no exacerbating or alleviating factors, no relation to exertion, no nausea, no vomiting, no diaphoresis. And she said, does not feel like my prior heart attack. She was lost to follow-up after her STEMI back in 2015. The only time she saw a physician after that was in 2018, where she had an echo done. And back then, her EF really hadn't improved much. The EF was about 35–40%, and there was mild to moderate hypokinesis in the anterior septal segment of the wall. So we went through a hospital history, no significant surgical history. Family history, only her grandfather had a CABG at age 62, but no history of CAD in the mother or her father. And she's never smoker, only social alcohol use and no drug use. Looking at her medications, she really isn't on guideline-directed medical therapy when she came in, which was a surprise. And she also told us that she was taking ramipril only occasionally because she started feeling dizziness. And it was 2 a.m. and I was talking to her, and I remember asking, did no one tell you to take ramipril because it would help your heart to improve its function? And she said no. So that's a huge red flag. But at least she's on an SGLT2 inhibitor for her diabetes, which is good. Physical exam, pretty unremarkable, really no signs of any heart failure. And she wasn't hypotensive or anything. And labs, so troponin was negative on admission. This was way before the days of high sensitivity troponin. BNP was 126, A1C is 10.4%, and the LDL is 101. Interestingly, this 101 is on 2-year therapy of rosuvastatin at 40. So that's also a red flag. Admission EKG, sinus with occasional PVCs, poor R wave progression, but nothing new, nothing that showed new acute ischemia during this admission. Unremarkable chest X-ray, had a CTA done of her chest when she came in, no pulmonary embolism, no aortic dissection. By the time we saw her, she had almost, I think, 5 troponins drawn, and they were all negative. So I guess the question here is, what would you do? No further ischemic evaluation, but in this lady with such high risk, a history of a STEMI, there was no way we could send her home without doing additional testing. Now, ideally, we would have loved to do a CT, a gated CT of her coronaries, but sometimes it's not available in the middle of Saturday night. So we went over the nuclear stress test, which we done on Monday, and you can see there, it was an exercise stress test. She achieved 95% of her maximum heart rate on the treadmill, had no symptoms, there were no EKG changes, but you could see predominance of ischemia in the LAD circumflex vascular territory here. And then the post-stress EF was severely depressed, about 36%, and there was transient ischemic dilatation as well, and post-stress stunning. So obviously she needs further workup. She got an echo done. Let's see if we can get to the next slide. Yeah, so she got her echo done here after the nuke. There we go. Guess you could play them individually, that's fine. So LV size, compared to 2018, it's mildly enlarged. LVF still moderately severe depressed. EF's like 34%, and regional wall motions in all the apical walls. So really not much improvement from her echo from 2018. So taken to the cath lab to see what's going on. And you can see there's severe in-stent restenosis in the proximal and mid-segment with about 70% stenosis, where she had a prior stent in the LAD. And then in her circumflex, her OM2, about 80% stenosis prior to the bifurcation and 60% at its bifurcation. For her, and then, sorry, go back there. And then in the ramus, I think we'll see that better here. The ramus had a 60% stenosis in the mid-segment. RCA was otherwise good. She had an LV-gram done. It's hypokinesis of anterolateral and apical and mid-inferior wall. So really, present on her, present on the echo, and this was what we saw in 2015, but we'll get to that later. So the decision now with this in-stent restenosis in the LAD is, what are we going to do? Are we going to do PCI? Are we going to do CABG? I mean, she's a young lady. We should give her every option for revascularization. Or just medical management. And her risk score for CABG was actually really low, her STS score. But then, so we decided to go back, dig into her chart way back in 2015. So back then she had presented with substernal and epigastric pain, associated with nausea, vomiting of 3 days, felt like reflux. So she had symptoms for 3 days before she actually presented. EKG said STEMI, and I'll get to that later. It's not very clear cut, but a troponin on admission then was 125. So this was an admission EKG. You can look at the interior and lateral leads. So maybe some ST elevations, but not clear cut. She got to the cath lab after a delay of a few hours from her admission, and this is what they saw there. So again, with the severe LAD stenosis, you can see there in the proximal mid area, and then some. They were thinking maybe in the ramus there was some distal thromboembolic disease. So she got intervention done. She had, obviously stents put in her LAD, and the ramus, they attempted mechanical thrombectomy but failed. So they did a thrombolytic infusion of TPA into the ramus back in 2015. Right coronary was, again, still had that 40% lesion, it hadn't progressed compared to this admission, but the LV-gram, EF was about 35% with those wall motion abnormalities that we mentioned before. So post-MI, this was in 2015 when she presented, after the STEMI, she got PCI, she had, cardiogenic shock, heart failure, was a balloon pump for a period of time because she was hypotensive, tachycardic, pulmonary edema from, respiratory failure from pulmonary edema. She was diuresed, weaned off the IABP, did really well. This was an echo back then, so again, not too different from what we're seeing now. So EF about 30-35%, and similar wall motion abnormalities. So just in summary, so you have this lady who's coming in, not typical chest pain, troponins negative ×5. She had a cath done. She has in-stent restenosis where she had a LED stent before. The question is, did she infarct any muscle? Is there anything worth revascularizing? And we don't really know that answer. Is it worth putting her through CABG to revascularize what we call dead muscle? So we don't really know. And the wall motion abnormalities are kind of the same. They really haven't improved. So this brings us to revascularization. Now, there's obviously different schools of thought between, a young person, maybe we should just go ahead and revascularize her anyway. But we have advanced imaging now. And there are many options, there's PET, there's standard thallium, you can do dobutamine stress echo, less done, and obviously cardiac MRI. And we know from our own data that, anyone who has viability, when we revascularize them, their EF improves. Just a brief view of the guidelines. So it's a grade 1 recommendation in the Canadian guidelines that cardiac PET and CMR should be used for evaluation and prognostication of patients with ischemic cardiomyopathy and a left ventricular dysfunction. And how we do it on MRI is basically we look at the amount of scar present, and obviously the territory of the scar tells us what territory the infarct is in. I won't get into details today, but we have strong data that shows that if the scar burden is what we consider limited, less than 50% as assessed on cardiac MRI, then revascularizing them improves their wall motion, improves their ejection fraction. And as well here, you can see, the wall thinning that's associated with what we thought was scar you might see on the echo, actually with revascularization in people, again, with limited scar. So that's less than 50% on CMR, their wall thickens again. So they recover their function. So she got her CMR, and basically what we saw was, obviously ischemic dilated cardiomyopathy, severe LV systolic dysfunction, some mild RV systolic dysfunction, and then transmural MI in the LAD and left circumflex territory, some partial viability in the LAD territory, in the basal to mid portion, and obviously limited in the circumflex territory. But RCA territory is completely viable. And that's, you can see, I'm going to pull this up later. Look out for these white patches here. So very beautiful images, and you can almost, you can clearly see the amount of scarred tissue here where it's non-viable. And so this doesn't get better than this. So we decided to proceed with PCI because we didn't think the benefit of CABG was as much given her CMR findings, but still worth revascularizing. We did consult CT surgery, obviously, and talk to them about it. So she had drug-eluting stent placed where there was severe ISR in her mid-LAD, and 80% lesion in her OM2 was also stented with a pretty good result. So on discharge, she was doing well, symptom-free. I think she's due for a repeat echo in July. She's already followed up with us. It's always a good sign. She was discharged on a life vest, and she needs aggressive risk factor modification. Remember that I said her LDL was 101 on 2 years of rosuvastatin and high-intensity dose of 40 milligrams. So, consideration of PCSK9 would be key, and obviously diabetic control. So I just want to talk about, MI in young females. Basically, among symptomatic women and men, the subset of relatively more men are chosen to undergo coronary angiography, which reveals that a majority of men actually have an obstructive CAD pattern versus a microvascular CAD pattern in females, or what they call microvascular coronary dysfunction. The medical therapy, interestingly, selection for aspirin, beta blockers, ACE inhibitors, what we call guideline-directed medical therapy in the setting of CAD. More males are discharged with it than females, interestingly, and you can see accordingly the death in MI and follow-up is, as a result, more in females than in men. So there were two good registries that I wanted to determine if the awareness campaigns that were started in 2003 about this disparity in MI in young females, to try and improve it, whether reduction whether these awareness campaigns were associated with a reduction in time to hospital presentation for MI, and to determine if gender disparities in diagnosis and treatment exist. And basically what they found was, women were older and more often had diabetes and hypertension, women less likely to have an EKG performed within 10 minutes of hospital presentation, less likely to be cared for by a cardiologist, less likely to receive acute heparin, ACE inhibitors, and GB2B3A inhibitors, and also less likely to receive aspirin and ACE inhibitors and statins at discharge. Interestingly, less likely to receive cardiac catheterization and more likely to receive stress testing. And if they received a cardiac catheterization, they waited longer for it. And among patients found with significant CAD, PCI was performed similar proportion in men and women. But overall, women were at higher risk for unadjusted in-hospital death, reinfarction, heart failure, stroke, and also red blood cell transfusion. So the key point is that the mortality in women, there's more women than men die during hospitalization following an MI, but the mortality is disproportionately higher in young females here, as you can see. And that might be as a result of all this that I just mentioned. We talked about, increased in-hospital mortality secondary to higher risk profile, despite adjustments of risk factors, and increased vascular complications as well, despite less aggressive anticoagulation regimens, over time, over the years, and smaller sheath sizes and early removal. But there's still 1.5 to 4 times more chance for a vascular complication in females compared to men undergoing PCI. Now, the Virgo study, tried to see why this was the case. So basically in women with symptoms, and this specifically in young females, more than the other registries that I mentioned. So a lot of females thought that their chest pain was related to stress and anxiety, while in men, they thought it was more related to a muscle strain. For men, when they had this chest pain, they were more worried about a heart problem, but in females, they were more worried about it was related to diabetes or hypertension or something else. And women in general present later to the hospital, as you can see here, for more than 6 hours. It's definitely a lot more in females than in men, and the median time is about 3.2 hours for a female presentation to hospital from first symptoms, and about 2 hours in men. And those who sought medical care, so it's also a physician issue, 54%, or 53% really in females, the provider thought that the symptoms were not heart-related. Unlike in men, there's only 36% that the providers thought it wasn't heart-related when they presented with chest pain. And we talked about, time to presentation, significantly longer in women than men. And no measurable reduction in decreased time to presentation, after all these awareness campaigns were started back in 2003. So I'll skip this slide real quick. So the take-home points here, always have a high suspicion of MI in young females despite the lack of classic symptoms. Your cardiac MRI is invaluable for viability to guide revascularization. And these disparities, which I talked about, are still present in 2018. So still more females than males don't receive guideline-directed medical therapy. There's longer door-to-balloon time, more bleeding events, and in-hospital mortality and 30-day mortality is higher. So this was a study that that wanted to see if a 4-step protocol would help improve these disparities, and it did. So we know that we have room for improvement and that we can do it. And then I'll leave some time for the panel to answer some questions if anyone has any.
Thank you, Dr. T. Does anybody have any questions for our panel or any comments? That was an excellent presentation, by the way. Thank you. Yes, Ahmad. Yes, she was. And you bring up a really good point. Most of these women, because I have a bunch of them in my clinic who have delayed treatment like this, they all have diabetes, which puts them at highest risk, right? So anybody who comes in with the highest risk factor, which is diabetes in women, you have to assume it's their heart before anything else. But unfortunately, I think we're still missing a lot of these people.
I think I want to point out at least two things with this case. And very nice presentation, Isaac. I was actually the attending with him on the weekend when we got the nuclear stress test results. One is the issue with cardiac MRI and viability, and there's a great summary of Dr. Kim's and Dr. Shah's work showing that we can first see scar with CMR, and then the fact that thinning on imaging modalities doesn't necessarily correlate with infarct. The way this works is the fact that gadolinium actually permeates the fibrotic tissue, the scar, the infarct, the myocardium that's not coming back. And this allows us to actually see in a one-to-one fashion scar on CMR. So one thing that's nice about CMR is that we can actually claim to see the infarct, whereas with other modalities like nuclear and CT PET, we have to infer it based on absence of perfusion and all. So very nice summary. The second issue is, as you guys are pointing out, she's a diabetic. This is a patient who's had prior MI, so this is now a secondary prevention issue. I know in the 2013 prevention cholesterol guidelines that we emphasized putting on statins, and unfortunately we went away from targets from there. It's now nice that with the 2018 and 19 updates that we've gone back to treatment targets and now emphasis on trying to lower risk by achieving LDL targets of less than 70 in this case. And I think that's where one issue with this patient, where the ball got dropped, she was left on Crestor and then not given any further preventive treatment, secondary prevention treatment with that.
This is just one more comment, was that the chances are this patient has microvascular ischemia and dysfunction and diabetic cardiomyopathy, most likely because of the nature of the coronary artery disease. Even though there was focality there, there's pretty diffuse disease and based on the caliber of the coronary arteries. So, I mean, it is possible. I mean, we'll see. Time will tell. It sounds like this patient may continue to have symptoms, and, you know, her wedge pressure may dictate her, you know, exertional symptoms of chest pain and so on and so forth. So we'll see. But right now she's doing better. Is that, Isaac, is that true? Or?
Yeah.
She follows up Dr. Kurrelmeyer, so that's a good part. She's due in July for a repeat MRI and echo to see if her cardiac function improved with revascularization, and I'm hoping that it did. And then obviously risk factor modification, talk about PCSK9 inhibitors and good diabetic control. So we'll know more in July, next month.
Yeah, I was just going to add, you know, so in 2015, she has an MI. Granted, she was in shock and all, but her peak troponin was 180, if I remember. Not the largest of the anteroapical MI. I mean, we have seen patients with more than 500 where we are really worried about absolutely wiped out and scarred out. I think there is a lot of viable myocardium to that LAD. Now, that being said and done, our angiogram here today, yeah, it's 70% stenosis, and it is definitely there. As to what we decide how to revascularize is up for grabs. I think there are many approaches. Obviously, one of them is to do a drug-eluting stent in an ISR patient with diffuse ISR. It should be IVUS-guided or image-guided intervention. But remember, this is a young lady with a low STS score, and if you look at her coronaries, I can literally vouch that there is not a single spot in that LAD which is free of disease. This patient has probably very aggressive, severe form of diabetic vasculopathy to the extent where these kind of patients can do very well with the internal mammary artery, and I'm an interventionalist saying that. So. But that being said and done, I think if there is any textbook indication, would be this one. I think this patient, if you look at our data on viability and their outcomes, you look at stage and the long-term stage, you know, it's up for the grabs. But I mean, we didn't have CMR data with that on viability. But nonetheless, I think there is a lot of viable myocardium in this lady's heart at that apex in spite of her STEMI. Revascularization is a good idea, but I probably would have considered a LIMA to LAD.
So, you know, that's exactly what we were thinking when she was turned down by the surgeons because it wasn't viable. We thought we could buy her some time by revascularizing her percutaneously and then rechecking her viability and her EF. If either one improves, then we have more of an argument to go for the LIMA, because I totally agree with you that she's so young, that was definitely a better option.
So, Dr. Shah, I just feel like the data that Isaac presented, pretty aggravating, isn't it? For like women missing so much coronary disease. what is being done in the interventional world to circumvent that? Should we lower our thresholds? Should we change the way we describe angina in women?
That's very true. I mean, it's a big challenge. I mean, time and again, I've been doing this for 15 years, and I would take care of the husbands, and the wife comes with them every clinic visit, every 6 months, only to see them in the ER saying, oh, I was just fatigued, I was just tired, and here we go. So there are a lot of silent CAD. But young women is such a difficult entity, especially to identify young women at high risk requires experts. And we are glad we have Dr. Kurrelmeyer to focus on that because it's something we are constantly, at fault of under-detecting. But from the interventional world, I think for us, our data on stenting, for example, are getting better. I think we are moving more and more towards image-guided PCI. We recently had a IVUS-guided PCI data. Now remember, your TLR rates in all comers stent is about, I would say about 6 to 8% per year, and then 1 to 2% every year after that. So younger you are, at 10 years, it will add up. It will add up to about 20% TLR rates. However, in image-guided PCI, IVUS-guided PCI, for example, our TLR rates are almost half of that. At 1 year for sure, maybe even up to 3 or even up to 5 years. So I think we can do much better with optimizing the stent sizing and going from healthy to healthy segment. I think we are getting better at PCI, and the second generation or the third generation DES, as you will call it, has done very well compared to a decade ago. But that being said and done, other than Lima, I think vein grafts are up for debate, up for grabs if there is a mortality benefit over DES. But in a young patient, a Lima with a diffusely diseased LAD should be the ideal therapy.
A question for you. How much ischemia did she have on her exercise test, on the nuclear? Did she have a large amount? Because her MRI truly shows completed infarction in the area where you see wall motion abnormality.
Yeah.
And the question is, at least from a clinical point of view, this individual has had chest pain for 4 days, no acute changes on the electrocardiogram, troponin completely negative, and you wonder what the etiology of the chest discomfort is. And I doubt, just from what you show us, that she will have any recovery of function the classical way. The classical way is looking at ejection fraction, which is really a crude way of looking at the recovery of function because you don't know what the stress-induced recovery would be in an individual who has a lot of scar like this. You could also have islets of functional myocardium, if you will. They're islets, and that may give you chest discomfort, but if you revascularize, this function may not improve because of what's called a threshold phenomenon. Once you have a certain percent of the myocardium that is infarcted, you're not going to see thickening, and you're not going to see an improvement in ventricular function. So I really doubt that this individual will have an improvement in ventricular function based on what you showed us. I wonder what her symptoms going to look like and whether even indeed the symptoms were ischemic in a true fashion, meaning she could have a high left ventricular end diastolic pressure and inducing ischemia this way as a multiple factor. So, but I think the best thing for this individual is to tighten her risk factor as much as possible, optimize her heart failure or subclinical heart failure as much as possible, and hope for the best.
Yeah, I could not agree more. That is probably the key point on this case is about LV recovery. We often struggle with progressive LV dilations on these patients, but I think, Dr. Reisner is here. We had recently a case, microvascular disease, especially in these diabetic patients. It is so underappreciated, and that can be more responsible than that LAD, which is, to a certain extent, in my honest opinion, is a little bit of an oculostenotic response for us to go and revascularize and hope for the best. But nonetheless, this patient probably either has LV dilation from progressive stretching phenomena, but also maybe has a lot of microvascular ischemia.
And at the time of her symptoms, it would have been nice to write her a cath because I have a feeling this patient it was hemodynamically mediated, possibly.
Do we have an LVEAP from her cath?
Yeah, I think it was LVDP when time of cath was 16, if I remember correctly. Yeah, 16.
Just one more point, I mean, minor point, but in advocacy for this patient, if I'm the interventional cardiologist, I would not have done an LV gram. And the reason for it, this is a diabetic patient, and you want to think about the total information that you're getting. And you had enough information that the ventricle is depressed. You know where the wall motion abnormality is, right? I wouldn't mind going in with your pigtail and measuring the LV-EDP, so at least you know what the filling pressures are, but I would not have done an LV gram.
I just want to make a couple of comments. I mean, it's a very nice presentation and a very interesting case. First thing, I think, when a patient like this comes into the ER, there's sometimes now a tendency to say, hey, could we do a CTA on a patient like this? I think it's important to keep in mind, though, that CTA, the value of it, the strength of it is ruling out disease. This is somebody who already has disease, who's got a stent in place. And yes, sometimes they can use kind of altered filters and stuff to try to get an idea if the stent is patent or not. But really, in somebody who has a stent in place, CTA is not the test of choice. So you really want to do perfusion imaging, and especially in a lady like this who may have a lot of small vessel disease. I echo Bill's point. I think that, based on all these MRI scans that I've looked at, I think that it's unlikely that this lady's wall motion in the distal LAD territory is going to improve, because I think there's significant amount of scar there. And as a result, I don't think you're going to have much of an improvement in her EF on follow-up. I think it's important, though, to keep in mind you want to save the rest of the myocardium, and that's where aggressive secondary prevention is going to be key. And then I think the other thing you're going to have to think about is also arrhythmic risk in this lady as well down the road.
Great presentation again. Just one more point to add regarding women, patients like this. These patients, women, especially younger women, have been underrepresented in clinical trials in cardiology in general and interventional cardiology in particular. So I think one thing that there is a push for in today's day and age is inclusion of more women in all kinds of clinical trials. And I think we have a long way to go to learn about cardiovascular disease in women such as these.
Okay, so we're going to switch gears. Dr. Thakkar is going to present our next case, which I think you'll find equally interesting.
I guess while we're waiting, let me just ask a question to Alpesh. In a lot of these younger women where obviously you've got some epicardial lesion, but you're also worried about a lot of downstream lesions as well, are you guys routinely doing some kind of imaging in the cath lab that can help to identify both macrovascular and microvascular components?
Yeah, I mean, I think it is done more in an academic fashion. Now we have migrated towards FFR, but that is again more to assess epicardial lesion rather than microvascular disease. Coronary flow reserve, which was historical and probably one of the best tools we have had in assessing some degree of microvascular, is really not practiced anymore. But nonetheless, I think sometimes the challenge we have is this issue of oculostenotic response, where we see a lesion, we want to fix it, and we just can't resist our urges to do that. And unfortunately, that does not always translate to long-term clinical benefits, and that is one of our Achilles heel, so to speak. So I think anybody with diabetics, and that's probably one of the reasons why diabetics have had relatively poorer outcomes with PCIs, because there's so much more to those patients.
All right, good morning. So our next patient is a 22-year-old lady who presented with a chief complaint of chest pain, palpitations, and shortness of breath. She'd been having these symptoms for about 1 year, and she felt like they were exacerbated with stressful situations, but she attributed them to deconditioning. Now she presented to us with an acute worsening of her symptoms. Her other history includes hypertension, obesity. Medications include combined oral contraceptive pills. She's never smoked, reports occasional alcohol use, and does not have a family history significant for premature coronary disease. On review of systems, she was positive for chest pain, shortness of breath, palpitations, anxiety. Physical exam was remarkable for tachycardia. Her labs were positive for a troponin that peaked at 48. Her EKG showed sinus tachycardia, a left bundle branch block. We did not have her prior EKGs. Her initial echocardiogram showed overall hypokinesis and a decreased ejection fraction in the 30s. And so she was taken to the cath lab. And what we found in the cath lab was that she had a subtotally occluded LAD and an occluded circumflex. This is another projection showing us that we really cannot see the circumflex and the LAD is occluded. Her RCA, on the other hand, did not show any significant lesions, and we did note collaterals going from the right to the left side. Her CTA showed a subtotal occlusion of the proximal and mid-LAD segments, a subtotal occlusion of the first diagonal, and a total occlusion of the proximal circumflex extending into the first obtuse marginal. So based on her age, her atypical angiographic findings, where her left system was almost completely involved with sparing of the right, the consensus was that her presentation was likely being caused by spontaneous coronary artery dissection, or SCAD. And so the question at this point was, what is the optimal management for this patient? Should she be managed conservatively? Should she be revascularized by PCI or CABG? Or should she be put on heart failure medications and then eventually be evaluated for advanced therapies? So after a lot of deliberation, the final consensus was to conservatively manage this patient because PCI, given the extensive disease, was not a good option, and she did not have good revascularization targets for CABG. So she was started on guideline-directed medical therapy for her heart failure. She was given a life vest and referred to cardiac rehabilitation. At 2 months, when she came back to see us in clinic, she still had chest pain. She still had a residual troponin leak. Continued to manage her conservatively. Then she came back at 3 months with life vest alarms for wide complex tachycardia, and also had persistent symptoms at this time. So in the setting of a failure of medical therapy, she eventually ended up undergoing a high-risk coronary artery bypass, followed by resolution of symptoms and an improvement in her quality of life. So with this in mind, I will briefly review spontaneous coronary artery dissection, or SCAD. SCAD is defined as a spontaneous tear in the coronary arterial wall that is not traumatic or iatrogenic, and it represents nearly 1.7 to 4% of all cases of ACS, and it is one of the most underdiagnosed causes of ACS. An overwhelming majority of SCAD patients tend to be women. In this cohort of 327 patients, 91% were women. And these patients tended to be in their 40s and 50s. SCAD is associated with a number of other conditions, the most common of these being fibromuscular dysplasia. the reported prevalence of FMD has been 25 to 86% in different cohorts of SCAD patients. Other associated conditions include arteriopathies, connective tissue disorders, the use of exogenous hormones, like our patient was on oral contraceptive pills, systemic inflammatory diseases. So how does SCAD occur? There are a couple of theories as to how it occurs. One theory is that an intimal tear is the inciting event. Another theory is that SCAD is caused by spontaneous hemorrhage into the media from the vasa vasorum, causing a separation of the coronary arterial wall. Regardless, SCAD is classified angiographically into three main types. The first type, which is the classic appearance of a dissection where you see dye hanging up in multiple lumens, you see multiple radiolucent lumen. Type 2 SCAD is when you see a long, thin lesion that is over 20 millimeters in length. And type 3 SCAD is when you see focal lesions that are difficult to differentiate from atherosclerosis, requiring further imaging like intracoronary imaging with IVUS or OCT. So this is a picture of OCT, and here you clearly see a tear in the intima, and this crescent here is the intramural hematoma. Similarly, this is an IVUS image where this crescent here, you can clearly see a separation of the wall, and you can see this intramural hematoma. Now, this is a study that was published earlier this year in JACC, and these authors aimed to study the natural history of SCAD. So they looked at 156 patients who had conservatively been managed. These patients had coronary angiograms at the time of diagnosis, and then follow-up angiograms as well. And the median time to repeat angiography was 154 days. And what these authors found was that at follow-up, a majority of the patients had TIMI 3 flow. And this included the patients who at baseline had TIMI 0, 1, or 2 flow, suggesting that over a period of time, if you leave SCAD alone, it tends to spontaneously heal. These patients were followed for a median of 4.7 years. And over this time, the rate of death was 1.3%, and the MACE rate was 37.8%. This is another study that looked at patients with SCAD, and this was a retrospective study that looked at 327 patients. And in this study, what they found is that over a period of about a median follow-up of 3.1 years, the rate of recurrent SCAD was about 2.8% per year. And what they found is that that patients who had hypertension were more likely to have recurrent SCAD. Patients who were on beta blockers were less likely to have recurrent SCAD. In 2018, the AHA published a statement, and this management flowchart is from this AHA statement. And they recommend that patients with SCAD who are clinically stable and do not have any high-risk anatomy should be managed conservatively. If they're clinically stable with left main or severe proximal two-vessel dissection, as was the case with our patient, then CABG should be considered, but conservative therapy is also reasonable. Patients who have active ongoing ischemia or hemodynamic instability should be urgently revascularized with PCI or CABG. In regards to conservative therapy, they recommend stopping systemic anticoagulation once the diagnosis of SCAD has been made, continuing aspirin for 1 year. The opinion on clopidogrel is divided, but it is recommended to continue it for up to a year, and the use of a beta blocker is also recommended. All patients with SCAD should be referred to cardiac rehabilitation with avoidance of high-intensity exercises or abrupt increases in the intensity of exercise. In regards to PCI for SCAD, it is important to be aware of the high rate of complications and technical failure of PCI due to the risk of propagation of the dissection by instrumenting the lesion. But done by experienced operators using the right strategy, there has been success with SCAD patients as well. In regards to CABG, there is a high rate of venous and arterial conduit failure. Other considerations for SCAD patients would be screening for fibromuscular dysplasia. Now, the gold standard for this is angiography, but practically what is done is CTA, and it is recommended that all SCAD patients routinely get a CTA of the renal, iliac, and head and neck vessels. At this time, there's a lot that is not known about SCAD, and there are a lot of ongoing studies aiming to look at the natural history, the outcomes of SCAD patients, treatment of SCAD patients, and so hopefully in the coming few years, we should see a lot more data coming out. And finally, this is a nice patient resource. This is an online portal that was established by the National Coalition for Women with Heart Disease, and this is basically an online forum not just for patients with SCAD, but all women with heart disease, where they can connect with each other, form support groups, kind of discuss their condition. So it's nice to kind of talk to our patients about support groups that might be available for them. So with this, I will end my presentation and open up for questions.
Thank you, Dr. Thakkar. That was excellent. Do we have any comments or questions for our panel?
I do have one comment. In that algorithm that we follow for bypass surgery or coronary, doing PCI or doing just conservative management, you don't have a depressed ejection fraction in the mix. So we don't know what we do if they have depressed ejection fraction versus a normal ejection fraction. And this lady was somebody that was followed on the heart failure service as well. And that was the caveat where we don't know whether she would have benefited from doing bypass surgery earlier on.
So
Let's
So I
see.
do have some questions. Since the LAD was involved, was there any consideration of doing a viability study in her? And then second is, I know you did a very nice work showing the association with different arteriopathies, and I know we attributed it to the exogenous hormone use, but did she undergo screening for any other vascular issues?
So, Dr. Kassi, do you know the answer to the first part of his question about viability study? Or maybe Dr. Thakkar does.
So she did undergo a CMR to look for scar, and she basically had 9% scar. So she did have significant viability. And in regards to your second question, yes, she did undergo screening for arteriopathy. She did undergo a CTA of her, head, neck, iliac, renal vessels, like I was talking about, and that was negative. We didn't find any abnormalities on that. She was also evaluated before she came over to Methodist. She was at another outside hospital. There she was also evaluated by a rheumatologist, by a hematologist to look for any other causes for her presentation.
And she had no recent pregnancies, just to throw it in the mix.
Right.
Pregnancy is considered a disease in our cardiology world, for the most part.
Yeah, that's right. She did.
I'm just concerned about the natural history of diagnoses. And let me explain. A new syndrome or a new way of thinking, SCAD, then you describe what the possible clinical scenarios are, and then you start, every time you see a young woman with chest pain and acute myocardial infarction, you start thinking about SCAD as opposed to other etiologies. So what I'm concerned about is we're overemphasizing this, and I just want to be a little bit more objective, particularly to the article in JACC where it says type 1, type 2, and type 3. I have no idea how you're going to differentiate type 3 from coronary disease, premature coronary disease, and other things unless you do further things. The classic one is on your left, the type 1, where you see a dissection. And I'm seeing more and more, whenever you see a younger woman with chest pain, acute myocardial infarction, that's the first diagnosis that comes to mind. And the concern is not overdiagnosing it. The concern is what happens with the lack of aggressive therapy because of much more conservative therapy as opposed to going in, besides risk factor modifications and medical therapy, addressing it. So I want to raise this for the panel and for the interventional cardiologists in the room, because I've seen some cases where I really cannot tell that there is a dissection, and maybe the best mode of therapy is actually to stent this lesion, et cetera, as opposed to withholding either stent or coronary artery bypass, just like in this case where there was only 9% scar. So I don't know how you're going to diagnose in this 28-year-old SCAD, where I barely see any arteries that are left, And I just want to make sure, for this audience here and the audience outside, that we're not just jumping over the bandwagon of a diagnosis without looking at it more objectively and seeing whether this is the disease, yes or no.
Yeah, look, this is a gut check in the cath lab. You got a 22-year-old coming to the ER with a non-STEMI or STEMI and non-STEMI in her case, having chest pains, and you run a catheter and you find an occluded or subtotal occlusion of an artery. Every interventionalist wants to put in a stent, right? I mean, that's kind of that's how we would think. Well, interestingly, SCAD is very different from atherosclerotic coronary artery disease. I mean, the progression has actually been very well written in the earlier paper this year, but most interventionalists would know this, that 85 to 90% spontaneously heal. So if I were to give you guys one message, say spontaneous dissection is equals to spontaneous healing. Almost 85 to 90% of those coronary arteries spontaneously heal. Instrumented wiring, balloons, stents, even imaging to a certain extent, even introducing catheters is best discouraged because we can traumatize those vessels knowingly, unknowingly. PCI outcomes have not been the greatest in scarred populations for varieties of reasons. I know Akanksha talked about a couple of them. There are some technical challenges, but even bypass surgery outcomes are not great. And I tell you why. I think the conduit patency is very low in those patients because the de novo artery, the native arteries, more often have healed spontaneously than not. So I think we should be very careful in choosing any revascularization strategy early on. Now, there is a debate about do we do a scheduled angiogram down the road, 4 weeks, 8 weeks to see. I don't think that is encouraged. You just follow those patients clinically. This patient had, I understand, ventricular arrhythmias or now chest pain that's another, I just want to, patients with scar, remember these are young women. You're going to do a cath, and let's say you say, well, oh, it's a SCAD, we believe it's going to heal. Go home. Can you imagine? They are so stressed out. They will continue to have chest pain. They will continue to worry about this. So be very careful. Now, this is a different story. This lady had, I understand, some troponin release on repeat. But I would have taken the opportunity of probably restudying that before sending her for bypass surgery to kind of redefine the anatomy. I don't know if you guys did that. But again, as a general rule of thumb, it does not behave the same natural course, especially the first few months. Now, that being said and done, remember, SCAD is like, you guys been to arcades, whack-a-mole game, right? You fix one, second one comes up. So this SCAD is, that's why those patients have high MACE rates in spite of revascularizing, quote-unquote, the culprit artery on day one. So this is a very, very tough diagnosis for a young woman.
Yeah, I just want to.
Let me address you didn't address the question. No, I mean, meaning, just looking at the angiogram, take away 28-year-old and said, this is 60 years old, right? Yeah. How do you, for us to take a conservative approach versus an aggressive approach, we have to have a solid diagnosis.
Yeah.
Right? So if we take away age, I mean, it could be 35, it could be 30, it could be 40, right? We have to be able to have a solid diagnosis for us to refrain from doing other things. No, I understand it.
Yeah.
But from the way it is classified at this stage of the game, besides the classic, right? I'm seeing almost anybody who comes in on the younger age group of women, that's the first diagnosis comes to mind, and no further diagnostics occur.
Yeah, and
and I understand that defaulting that to every time to SCAD is a little risky road to take. But I think what in the cath lab, these patients would come in, first and foremost, we should give them the Kleiman dose of nitro. I don't know if yeah, Dr. Kleiman's here, right. So we should give this patient, for example, tons of nitro, make sure there is nothing else going on. But that being said and done, flow is huge. If there is more than TIMI2 flow, I would urge to stay conservative, give this patient some more time. But if there is flow compromise, there is all the reason for us to fix it. We can fix it, but there are challenges intra-procedural as well as long-term. And that's what I was just trying to emphasize. But if the flow is limited, then obviously we must intervene. And we can do that successfully with IVA's guidance.
I just wanted to add on to Dr. Zogby's point. It was purposeful to put two young women back to back with two different diagnoses. And that's the thing, if every single young woman is labeled with SCAD, well, then the first woman gets delay in treatment. Because their EKGs look very similar also at presentation. The one with the STEMI looked very similar to the one with the SCAD. So he's absolutely right. It's like, do you guys have any plans to incorporate IVUS or OCT or anything else in these young women who are presenting with ACS?
Well, I was just going to quickly comment, the less wiring we do to those vessels, the better it is. We really can do unnecessary trauma to those patients, to those vessels. Again, you got to come back to the cath lab, doctors.
Dr. Kleiman, did you want to comment?
Yeah, so, you know, look, it's always embarrassing to agree with the chief in public, but especially online. But, you know, the truth is, sitting 60 feet away, looking at an AVI file, I don't see anything on this angio that looks like a dissection. And then, so, you know, I question the diagnosis. It's certainly high on the differential, but to say, hey, this is SCAD, I think is quite a long leap. The other things to echo Alpesh's point, you know, there's a reason we don't like to stent these and we don't like to send them to bypass, and that these are bad arteries. You put a stent in, cover the dissection, and then you tear at the margins of the stent, and you end up putting another stent in, and you end up biting off a lot more than you can possibly chew. And the surgeons will tell you the same thing. They sew the grafts in, and these are just terrible vessels to sew into.
Just one comment on the treatment arm. You had 3 treatment arms, and in one of them where you said you would consider revascularization or CABG, it was patients who have hemodynamic instability or ongoing symptoms. So the comment I want to make is that if someone has hemodynamic instability and a classic dissection on angiogram, because type 3, you would have to look at risk factors, you would need more information. But if you have classic dissection, actually you don't want to revascularize because of all the problems. You can actually lose flow distally. The point is that there's no comment of instituting temporary MCS, which is likely to change the patient's prognosis in that algorithm. And as a matter of fact, in general, for ACS and hemodynamic instability, this is becoming something to come into play. So the point is that I think that temporary MCS, instituting early in someone who's hemodynamic instability, and particularly if it's classic dissection, I think that would be the preferred thing to do, and then go for conservative medical management initially. But not having that in the part of the algorithm, it's a little, Thank you.
So just a quick comment. One, very nice case presentation, and I think these two cases really bring up the fact that we need to start thinking a little bit differently than how we think about men. I just wanted to kind of make one comment with regard to the imaging to look for other causes. I think she's got oral contraceptives, and we're kind of hanging our hat on that. I think when you do an imaging workup to look for FMD, you do CT scans. I think it's important to make sure that you do a very high-res CT scan, because with FMD, if it's 2-3 millimeter pixel sizes, you may not be able to pick it up. So it needs to be done kind of in a specialized protocol.
Can I ask Dr. Goel, he's visiting with us today from Illinois?
So excellent presentation again. I think Dr. Zogby's point is very well taken. At the end of the day, coronary artery disease and atherosclerosis is much more common than FMD and SCAD. At the same time, we have all seen these young patients who are in their 20s or 30s, for instance, the first case. I think it's also important to keep the whole clinical context in mind. The first patient, for instance, was a poorly controlled diabetic, had already had coronary artery disease, had a stent, so more likely atherosclerosis, whereas this one is a very young patient, 22-year-old female, yes, it's very, very difficult to tell based on the angiogram that you showed, not a classic SCAD type angiogram, but absence of any traditional risk factors or drugs or anything else. So, this is a very difficult clinical entity that we see few times a year in the cath lab. And as interventionalists, it is very, very important to be extremely careful not to institute the oculostenotic reflex, but use the whole clinical context, to guide us in making a diagnosis and managing these patients. Percutaneous intervention can be a slippery slope, as can be imaging. Although I have a question. This patient had a CTA. Why was the CTA, was the coronary CTA part of the head-to-toe CTA? And based on the CTA, can you tell whether there is intramural hematoma and dissection? Are there any, suggestions from the CT experts in the room?
So in regards to the CTA was not done as part of the search for FMD. It was more to look at what the vessel sizes were, if there were revascularization targets, or the time that CT surgery was consulted. It was not able to show us a classic dissection or a classic intramural hematoma. What it told us was that the vessels were occluded. But I'll, hand it over to the CT experts in the room.
Unfortunately, I don't think we have a CT expert. Next time when we do this, we'll make sure there's one on the panel.
And the other statistic that I came across when I was reviewing the literature for this presentation was that only about 30% have that classic type 1 appearance on angiogram, and 70% tend to have type 2 or type 3. And so that makes it even more challenging in a majority of these patients to kind of differentiate between SCAD and atherosclerosis.
Maybe a last question to our interventionalist, the panel, and the audience. In a type 3, where you really cannot tell, why, I know there may be a risk, but why not use IVUS or OCT? For you to say, no, I would not do an intervention with PCI versus yes, I would, et cetera, you have to have the diagnosis, and that's my concern. And, if you're starting proximally where there's no dissection, right, as soon as I get into the lesion, hopefully I'll understand something as to what's going on. So what I'm aiming for and what I'm pushing for is a diagnosis.
Yeah.
Because it alters the way you're managing these patients.
That's very true. And look, so give nitro, see how the coronaries behave, how the flow behaves. But the threshold to drop a wire or an imaging device like an IVUS or OCT, I'm not saying it's prohibitive. It's just that as a general guideline, we discourage that, because remember, not 10, not 20, not 50, not 70, 90% of those coronaries spontaneously heal at 4 weeks. Report series after series have shown that, and that's been said and done. Yeah, it is very easy for us to drop an IVUS and see if there is any atherosclerosis with that. And you're right, we will change how we treat those vessels. But sometimes I think more cautious approach would be not to rush to intervene. Diagnosis is great to see if there is atherosclerosis, but if there is no atherosclerosis and conclusion is that this is a type 3 SCAD, it is best to leave it alone if there is good flow.
So let me ask you another question, because we've seen this in 60-year-old women with risk factors who've had SCAD. In somebody like that, would you change your mind and absolutely drop an IVUS?
Yeah, if those coronaries are non-atherosclerotic, non-traumatic, non-iatrogenic, and all we can find is SCAD, I would still push, as long as there is STEMI 2 or 3 flow, I would still continue to push for conservative medical therapy. And consider following that patient clinically, see how she does, and then consider repeating angiogram depending on the clinical scenarios. Usually, it is hard for our colleagues, for us, forget about cardiology, interventional cardiology is even more tough for us not to stent those. But again, the natural history of this, such a unique condition, argues against everything we know in the interventional world. And that's what I want to just caution everyone on. And especially our patients, is even tougher. You didn't fix me? But it is the way most of the recoveries happen. And remember, putting in a balloon or a stent or something like that is not a benign thing to do. You can increase, down the road events and so on and so forth. So look, all I'm saying is if the patient can handle it, treat it conservatively, assess clinically, and then go after those arteries depending on what is the status after that.
Okay, it's now 10 past the hour. We had another case for y'all, but Dippin will have to invite us back if you really want to hear it.
So really, I want to congratulate Karla and the entire panel and the fellows for the presentations. These are very, very phenomenal cases. So we've got one more grand rounds next week, and then we'll adjourn for the summer. So thank you again, and we'll see you next week.